Hey everyone, welcome back to the channel. In this video, I want to go through some of the biggest news and studies from 2024 in the world of acne. To start, I want to talk about the controversies about benzene and benzoyl peroxide containing products. In March of 2024, Valisher released a report describing that when benzoyl peroxide products are exposed to high temperatures, they can form concerning levels of benzene, which is a known human carcinogen. And this isn't an issue of contamination. It's not there's benzene in some of the ingredients that they're using. It's a fundamental aspect of the molecule benzoyl peroxide. It has this potential to break down, particularly when exposed to heat, to benzene. And benzene is not something that we want to have around us. We want to try to avoid it if we can, because higher exposures to benzene are associated with various cancers, particularly leukemias and lymphomas, types of blood cancer. Now, in Valisher's report, they primarily share data at 50 degrees Celsius, these very warm temperatures. That's 120 degrees Fahrenheit. And so the question was, at more reasonable temperatures, is this happening? Is this something that if the product is stored appropriately, we need to be worried about? They did subsequently release a paper where they incubated benzene at 37 degrees Celsius and showed much lower levels of benzene were forming, but still some was happening. Now, again, 37 degrees Celsius is 98 degrees Fahrenheit, still a relatively warm temperature. Most people aren't storing benzene in these kind of conditions for days and days and days on end. Even more recently, they released a report where they purchased various benzoyl peroxide products off the shelf and looked to see whether or not they had benzene in them. And the vast majority of products had almost no detectable benzene in them. However, there were some outliers, as you can see in this graph. There were some products that had potentially meaningful levels of benzene in them. And the first thing here is this really highlights that you can absolutely have benzoyl peroxide products without issue, that most of these brands and most of these products they tested were absolutely fine. But we do need to try to understand what is it about some of these products in terms of how they were formulated, how they were shipped, how they were stored, that might lead to some having higher levels of benzene than others, so we can improve the supply chain and minimize benzene as much as possible in these products. Now, a common misconception of this report is that Valisher showed that benzene is forming at room temperature, and they absolutely have not done this. None of these products were incubated under room temperature conditions and monitored for formation of benzene. What's been shown here is that some products, when you purchase them off the shelf, can have some levels of benzene in them, and now we need to understand why. And I think formulation, distribution, and storage are likely important factors that we'll learn more about as time goes on. And again, a big point here is most of the products were absolutely fine. Now, the other thing to think about is, okay, so there may be some benzene in these products. Is this clinically meaningful? Is this actually going to cause harm? And so the first thing to know is that benzene is not really absorbed through the skin. There's almost no meaningful cutaneous absorption of benzene. And so the risk here isn't going to be skin cancer from the benzene being on your face. It's going to be that it aerosolizes, that we inhale it, and that it increases our risk for the kind of classic benzene-associated malignancies. Now, unfortunately, in our lives, benzene is there. If you drive gas cars, if you live in an urban environment, if you eat food, you're unfortunately being exposed to benzene. We just are. And we'd love to make this as close to zero as possible, but some have estimated that the average person is getting exposed to maybe a couple hundred micrograms of benzene a day just through our routine daily living exposures. So let's do a thought experiment. Let's take one of the worst products that Valisher looked at. Let's look at something that had 10 parts per million of benzene, and that's worse than 85% of what Valisher tested at baseline. So 85% of the benzoyl peroxide products you can get are better than this. This is one of the worst ones you could look at. So let's imagine you used a gram of that product containing 10 parts per million of benzene. Well, that would result in about a 10 microgram exposure. And even assuming that all of this benzene becomes volatile as inhaled, right? The risk of it going through the skin is very minimal. So the real harm is potential is from it aerosolizing and us inhaling it. And the idea that in the volume of distribution of air that we're in, that we're going to inhale 100% of that, probably not. But let's imagine that we inhaled 100% of that. Well, again, in our daily lives, we're being exposed to more than 10 times that much benzene from other things. A gas oven is emitting about that much benzene every couple of minutes. And so while we'd love to try to reduce benzene as close to zero as possible, the likely incremental risk for even some of the worst benzoyl peroxide products is minimal to none. Another way to look at this is let's actually look at data in people who use benzoyl peroxide containing products. Are they at higher risk of having benzene detected in their bodies? Are they at higher risk of cancer, right? These are the outcomes we care about. So if we look at those who are using benzoyl peroxide containing products versus those who are not, this is data from NHANES, we see that there's no difference in the likelihood of someone having detectable benzene or the levels of benzene in their blood when they do have detectable benzene. And so again, this is supporting the incremental risk of using benzoyl peroxide containing products is probably negligible for a typical person. This doesn't mean we don't want to try to improve these products to have as little as possible. It doesn't mean we want to try and limit benzene in our world. We absolutely want to do those things, but the likely actual clinical risk of these products is negligible. Again, if we look at someone who's being, looking at the risk of cancer. So we look at those who are using benzoyl peroxide containing products versus those who are not, and we can compare their risk of cancer over the next, 10 years. We don't see any evidence of increased risk of hematologic malignancies, blood cancers like leukemia, lymphoma, or any cancer for that matter. So again, these data are reassuring that with routine use in typical conditions and typical ways that people are using benzoyl peroxide containing products, it doesn't seem to lead to a clinically meaningful increase in risk of cancer. Again, this doesn't mean we want to try to be thoughtful about how we use them and store them and formulate them, but the likely clinical relevance of this benzene is probably minimal. So what are the takeaways? So again, even if there is some benzene present in these benzoyl peroxide products, it's unlikely to be a clinically meaningful risk based on epidemiologic data and thought experiments. We definitely need more transparency from Valisure. We need more data on room temperature storage. We need more data on the impact of formulation and other characteristics of manufacturing and distribution, how we can improve our benzoyl peroxide products, how we can make sure that they're less likely to have this issue. And I look forward to hearing more from the FDA about this matter. Now, let's also think about what can we do as an alternative if we want to try and avoid it. And this is a real challenge. There's no direct alternative to benzoyl peroxide. We could try to use something like fluorine dioxide or dilute sodium hypochlorite or hypochlorous acid, other kinds of maybe antimicrobial strategies, but there's no head-to-head study of the disease. They probably don't work as well as benzoyl peroxide, which is arguably one of the most effective single topical agents that we have for acne. And ultimately, if we avoid benzoyl peroxide, then we're probably going to have to start using some more pill medicine treatments for people. More people are going to end up on oral antibiotics, on spironolactone, on birth control pills, on isotretinoin and Accutane, because their acne just isn't getting better. And those medications have risks too, including potential risks of cancer. Oral antibiotics are associated with risks of cancer. So we want to really be thoughtful about how we move forward. I think this is an issue that we must take seriously. We want to make sure we improve the supply chain, but we don't want to overreact either. I think completely avoiding benzoyl peroxide products is both probably not practical, is probably not really justified with the amount of data we have right now, and then it may actually put people at more risk of harm because of the alternative treatments that they end up using instead. Now, moving on, this year we had new guidelines on acne come out. And while we don't have time to go through them entirely in this, I want to highlight some new medications that have come out, the data around them, and kind of where I see them fitting into clinical practice. The first one I want to discuss is this triple combination product containing clindamycin, adapalene, and benzoyl peroxide. This is the first product that we have that combines these three major mechanisms of action in our topical acne treatment strategies. And boy, does this product work really well. When you look at IGA success, achieving clear or almost clear skin, about 50% of the people who are treated with this triple combination product achieve that endpoint. And that's actually really astounding. As you'll see in some of the other trial data I'm going to share, these are typically around like 20 to 30%. Usually things are about 10% better than vehicle or placebo for most trials that you see. This is like 30% better than vehicle. This is really impressive data in terms of getting people to clear skin. There's good improvements in both inflammatory and comedonal lesions, as you might expect. And people improve relatively quickly. Within 4 to 12 weeks, people are noticing meaningful improvement in their acne. This is another way to think about how effective it is, which is called a network meta-analysis. We might not have a head-to-head study of this versus some of our other common acne treatments, but we can try and use statistical methods to compare the trials. And when we do this, this is actually really the most efficacious single treatment that we have outside of isotretinoin for the treatment of acne. In addition, it was relatively well tolerated. We might worry combining a retinoid and benzoyl peroxide together might be a setup for irritation. And these trials, about 2 to 3% of people discontinued due to side effects. That's pretty on par with other trials of topical acne agents like topical retinoids and benzoyl peroxide. Notably, in a study looking at irritability just directly comparing this product to adapalene benzoyl peroxide, it was slightly less irritating than adapalene benzoyl peroxide. And that may speak to the optimized vehicle that it's in to try to allow the benzoyl peroxide and adapalene to be distributed more evenly and slowly on the skin, which may help reduce irritation. So this product, very effective, pretty well tolerated for a retinoid benzoyl peroxide product. Again, another way of looking at side effects in this network meta-analysis, about the same as other topical retinoids. You notice much better actually than something like trifarotene, a little better than tazarotene. Trifarotene is a medicine that is quite irritating and honestly not particularly more effective than other acne treatments. So it's something that I generally don't use a lot, but you can see compared to tazarotene, topical retinoids, benzoyl peroxide, adapalene, this is kind of on par with them. It's pretty well tolerated compared to other options that would be similar to it. Now, moving on to Clascoterone, this is a topical anti-androgen. This is really the first treatment that we have that can be used for anti-androgen therapy in men with acne, which is really exciting. So we can use this in both men and women because it's rapidly metabolized in the skin, the cortexolone. There's no systemic absorption of it. So there's no systemic anti-androgen effects. In the phase 3 trials, this was quite efficacious, kind of on par with most of our single agent topicals, about 20% clear, almost clear skin, IGA success, about 10% better than vehicle. Again, put that in comparison to the triple combination product, not quite that, but this is pretty typical for what we see for any single agent acne topical product. A little bit better improvement for inflammatory lesions and comedonal lesions. So this might be particularly helpful for those with more inflammatory acne. And this was really well tolerated. People essentially had no irritation or dryness or those kinds of side effects. So for those who have more sensitive skin, this could be a really valuable and helpful product. There is a potential risk of adrenal suppression due to the metabolism of cortexolone. I mentioned that is a steroid hormone in theory that could cause some adrenal suppression. In the phase 2 studies where they had people apply 6 grams a day, which is a huge amount, you'd go through the tube in just over a week. 7% of people had biochemical evidence of HPA axis suppression. Nobody had symptoms of adrenal sufficiency. Nobody had issues in the phase 3 trials. I do think this means we want to be thoughtful about not using it over a huge body surface area. But in general, I think using it over a reasonable body surface area, this is unlikely to be an issue. There was a head-to-head study that compared Clascoterone with tretinoin. And in fact, it was kind of, at least on a numerically level, a little bit better than tretinoin. It wasn't statistically significant all the time points, but the black bars are the Clascoterone one, the gray bars are tretinoin, and really at every time point for every outcome, it was a little bit better than tretinoin, which is pretty impressive when we think about tretinoin as kind of our standard treatment. When we look at that network meta-analysis I was mentioning, it was a very effective treatment. It was on kind of actually the higher end of IGA success compared to the other single agent topicals. Again, kind of on par with topical retinoids or other kinds of standard acne treatments. And it was extremely tolerated. It was the best tolerated treatment that they looked at. So I mentioned that triple combination treatment, most effective treatment they looked at. This was the best tolerated treatment they looked at. So again, for those with sensitive skin, this can be a really nice potential option. Now, it isn't a thicker vehicle. It is a twice-a-day medicine, so convenience and ease of use can be important factors here. It's not right for everyone, but it can be a useful tool in our treatment armamentarium, and it can complement our other classic treatments like adapalene, like topical retinoids, like topical antibiotics like clindamycin and dapsone, and like benzoyl peroxide. So, pairing this together with that triple combination product, you really hit all the mechanisms in 2 topical creams. So that's a pretty nice and relatively convenient regimen for someone. Moving on to pill treatments, we now have a narrow spectrum antibiotic called Sarecycline. And the goal here is take something like doxycycline, let's make it really good at acne and really bad at other things. And so you can see here that compared to doxycycline, minocycline, it's about the same effectiveness against C. acnes bacteria. But when we look at gram-negative enterobes, it's about 32-fold, 16 to 32-fold less activity against them. And this might translate to less effect on the gut microbiome or other good bacteria in our body and potentially less side effects. When we look at the phase 3 clinical trials, Sarecycline works pretty well. Again, about 20% IGA success, achieving clear, almost clear skin, about 10% better than vehicle. Again, most single agent treatments look like this when we look at acne trials. It works a bit better for inflammatory lesions and comedonal lesions. And this is often what we see for topical and oral antibiotic treatments. And it was very well tolerated. Very few people had issues with nausea or vomiting or other stomach upset. There were very few people who had yeast infections, about 1%. There weren't any vestibular side effects like what we see with minocycline, and Sarecycline should be less likely to cross the blood-brain barrier and thus less likely to cause those issues. And there was no evidence of phototoxicity in the trials. though I think it may be slightly phototoxic in practice and when you look closely at these data. It's certainly not to the degree of doxycycline, but it's probably still a little bit, and photoprotection is probably advisable for patients on sarecycline. So where do I see this fitting in compared to our other oral antibiotics? For me, actually, the main thing with oral antibiotics is trying to limit who we treat, trying to be thoughtful about, are there topical strategies? Are there opportunities to use hormonal strategies, procedures, isotretinoin? Are there other things that might be a better option? Because antibiotics are not a disease-modifying treatment. They're not going to make someone better in the long run. They can be a great bridge to other strategies because they work quickly, but we really want to be thoughtful about who we're using them in and think about, are there other better alternatives? With that in mind, I focus again more on limiting who we treat than how long. People, when you take them off, if that's the main way you're treating them, their acne is going to flare unless they've kind of aged out of their acne. And so rather than having people yo-yo on and off 3-month courses of treatment, I use it either as a bridge to something else, or we decide, you know what, this is the best long-term treatment. It has risks, it has potential side effects, but they're better than our alternatives, and this is what we're going to go with. I often will use doxycycline as my main oral antibiotic for acne. I try to avoid minocycline because of the risks of severe drug reactions and other side effects that are present with that we don't see with doxycycline. There's really not a lot of evidence to suggest that it works better. I do think sarecycline is a great option for our patients with acne. And if you take away the issue of cost and access, it's arguably just a better version of doxycycline. It's once a day. It has potentially less side effects, so we don't have a lot of head-to-head trials, and it has theoretical advantages in terms of being less disruptive to our good bacteria or microbiome. So it's a really nice option for those who have maybe more limited options where we are using oral antibiotics as a long-term treatment, who have comorbidities, maybe something like inflammatory bowel disease or other gut health issues, or just, if cost and access is less of an issue, less of a factor for that individual. Moving on to spironolactone, we're finally starting to have some really high quality randomized controlled trial data. We had the SAFA trial from the UK, which randomized about 400 women to either spironolactone, essentially 100 milligrams a day, or placebo. In this trial, people started at 50 milligrams a day for the first 6 weeks, then they upped their dose to 100 milligrams a day if they're tolerating it well. And about 97% of people are able to do this, which highlights that 100 milligrams a day as a dose is very well tolerated, and arguably we could probably start there for most of our patients, as we know that 100 milligrams a day is more efficacious than lower doses like 50 milligrams a day. Looking at their primary endpoint, which was quality of life, they actually looked at a patient-reported outcome, the acne QOL, at the 24-week period at the end of treatment. Spironolactone was statistically significantly better than placebo. They also looked at clinician-reported outcomes like investigator global assessment success, having clear, almost clear skin. And there was a marked difference between the spironolactone group and placebo, about 15% higher rates of IGA success. So again, on par, maybe slightly better than we just saw with sarecycline. From a tolerability standpoint, this trial gives us some new data about how well spironolactone is tolerated, about what are the rates of low blood pressure side effects or irregular menses. So we can see at 100 milligrams a day, when we compare those who are treated with spironolactone versus placebo, there wasn't really a particularly notable difference in the rate of irregular menstrual bleeding. And so at this dose, it doesn't seem like that's a common side effect. Definitely at higher doses, and we'll see at 150 milligrams in the FASTI trial, this does start to become more of an issue. And Alison Layden's work has suggested this too in observational data. So 100 milligrams a day is a pretty nice starting place. People don't tend to have a lot of regular menses. It works well. It's a nice balancing point of efficacy and side effects. The main side effects they saw at this dose were lightheadedness type symptoms, about 5% higher in the spironolactone group than in the placebo group, headache, kind of going along with that. And then there was a slightly higher rate of polyuria, going to the bathroom more often, though this wasn't statistically significant. Moving on to the FASTI trials, this was a trial in France, which compared spironolactone versus oral antibiotics. And in this study, participants were randomized to either spironolactone 150 milligrams a day for 6 months, or doxycycline 100 milligrams a day for 3 months, and then after that, they were on placebo for the next 3 months. Everybody in the study also was treated with benzoyl peroxide. And what you can see is that, at 6 months, which was their primary endpoint, spironolactone actually had superior outcomes in terms of people having sort of investigator global improvement compared to doxycycline. Even at 2 months, these are relatively similar. So we sometimes think of spironolactone as a slow treatment, but it was kind of keeping pace with doxycycline for most of this trial. Now, the challenge of this is there's no 3-month endpoint that they looked at, so we don't really know how people were doing when they were both on treatment. But we can see, in maybe a real-world use situation where we're trying to limit use of oral antibiotics, that spironolactone may be a better long-term control option. And certainly for adult women with acne, who often are going to have acne for many years, this might be a nice alternative to oral antibiotics for these individuals. We have some data from our group too, observational study, that shows that, if you look at treatment switching, so someone, they start in either spironolactone or doxycycline, a tetracycline, doxycycline, minocycline as their initial treatment, and then we follow them over the next year, how often do they switch to something else, suggesting that that wasn't working? And the people who are treated with spironolactone, it's about the same rate of treatment switching when we adjust for other potential confounders than those who are treated with oral antibiotics. So this is more data kind of suggests that spironolactone may be a really nice alternative to oral antibiotics for adult women with acne. And we soon have some data, the ST acne trial, where we're comparing spironolactone 100 milligrams a day versus doxycycline 100 milligrams a day in women with acne, and also looking at the microbiome that will add some more color to this picture and help us make informed decisions about what treatments we want to use. Now, moving on to lab monitoring for spironolactone, as many of you may be aware, work by Ross Masagimi, Bethany Slasher's group, and others have highlighted that potassium monitoring is of low clinical usefulness in young, healthy women. And in the updated 2024 guidelines, this is now specifically mentioned that potassium monitoring is not needed in healthy patients, but to consider it in those who have risk factors for hyperkalemia. However, if we look at our practices, potassium monitoring is pretty common, with about 50% of people getting checked at baseline and then 40% having it monitored. And unfortunately, when we do check it, the timing is not optimal. This is some work from our group this year where we looked at when people do check potassium, when are they doing it? Ideally, we should be doing it within 2 to 4 weeks of starting spironolactone. If someone's going to have hyperkalemia, this tends to occur quickly and then stabilize. And we really don't want to have someone going around with a potassium of 5.5 and not doing anything about it. So if we're going to check it, we want to do it kind of right after we start treatment. We won't want to do it when they come back 3 months later. And unfortunately, when we look at our practices, most of the potassiums that we're checking are more like 3 months later, not checking within 2 to 4 weeks of starting the medication. And so this is potentially an opportunity to align our practices better with evidence. Certainly, we want to be thoughtful about when we check it. But if we are going to do it, which I think can be quite reasonable, and honestly, any person who wants to, it is on the package label for the drug, and this is an off-label indication. If we are going to check it, we should make sure that we're doing it thoughtfully. We should be trying to do it within 2 to 4 weeks of starting the medication. Now, moving on to some new data about isotretinoin. We've had some of these meta-analyses looking at isotretinoin depression, suggesting that isotretinoin, on average, at a population level, is not associated with an increased risk of depressive symptoms. However, now we have a new meta-analysis in JAMA Dermatology from this year looking at suicidality, which also kind of mirrors this and shows that actually isotretinoin users are less likely to attempt suicide at 2 years than non-users at 3 years and 4 years as well. So if we think about kind of long-term outcomes, comparing those who are treated with isotretinoin to alternative acne strategies, isotretinoin is actually associated with a lower risk of suicide. And this probably has to do with it being such a good acne treatment. We know that acne itself is a risk factor for depression and suicide, and treating it effectively may actually improve people's lives and reduce their risk of these outcomes. However, there are, as some may be aware, lines of reasoning suggest individual patients do experience mood changes. And I think any of us who have treated a lot of patients with isotretinoin have experienced this. Vitamin A is associated with mood disorders and vitamin A toxicity. You can show in fMRI studies that isotretinoin can influence activity of certain regions of the brain. And challenge case studies really do support causality. You can give someone isotretinoin, they might have mood symptoms like irritability, depression, sadness, etc. You stop it, they feel better. You have them start again, they feel those same symptoms. So I do think there are individuals who causally experience these symptoms. I do think this is a real side effect of isotretinoin. And so how do we put this all together? Well, I think isotretinoin is associated with rare, a little bit difficult to predict, but meaningful negative effects of mood on some individuals. On average, though, our expectation, if we are, our expected outcome is that mood's going to improve and that suicidality risk is going to be less compared to other acne treatments, likely because it's so effective in treating acne. And this really, we want to be, again, thoughtful about patient selection. We want to use this in people who have acne as having a meaningful impact on their lives where we need a strong treatment. So in my mind, we shouldn't be afraid to use isotretinoin, even in those with a history of mental health issues. To me, that might be reason to use it to help address those, especially if those mental health issues are related to acne itself, and if effective treatment for acne might help to alleviate some of those symptoms. And then finally, just closing out with lab monitoring of isotretinoin. As some of you may be aware, there's a recent Delphi study by our group with Erasmus Academia as well, looking at what are the best practices for monitoring labs on isotretinoin. And the high-level conclusions are, checking some sort of liver test like an ALT and triglycerides or lipids at baseline, then again at peak dose, which is often around 2 months. And if those are normal, which is going to be true for about 99.7% of individuals, no further lab testing is needed. And this really, the 2024 acne guidelines start to bring this in. They mentioned that For patients undergoing treatment with isotretinoin, monitoring LFTs and lipids should be considered. They mentioned not doing CBC monitoring, which we agree with. So now these details are starting to make their way into the guidelines for those who are looking to streamline their lab monitoring practices to be a little bit more aligned with the evidence base that we have. So to summarize the year in review for acne, so we must take this issue of benzoyl peroxide and benzene seriously. I do think there are opportunities to reduce this issue so that we can make these products even safer for our patients. But as I laid out, I don't think this is really a clinically meaningful issue at this time, and I don't think we should overreact to it either. We have several new acne products that are really incredible. We have this triple combination clindamycin, adapalene, benzoyl peroxide product that's highly effective and convenient for those with acne. We have a topical anti-androgen, Clascoterone, that we can use in both men and women with acne that really has minimal irritation potential, which is great for those with sensitive skin. And so combining these two together really is you've hit the four main kind of mechanisms of action that we have with prescription acne treatments in just two products. Now, Clascoterone, it does have some limitations. It is a thicker vehicle. It's a twice-a-day medicine. So ease of use and convenience may be a problem for some, but for those who are motivated, who don't mind a product like that, it can be, again, a really great option. On the systemic treatment side, we now have a narrow spectrum tetracycline, Sarecycline, which is a really effective option for acne. It seems to have better side effect profile than other tetracyclines like doxycycline and minocycline, though we still need some head-to-head studies. And it potentially has a theoretically lower risk of negatively affecting our microbiome, which is another advantage of it. We now have increasing data to support the efficacy of spironolactone and hormonal therapy for women with acne, and this still probably is an underutilized treatment. Even though its use has been growing, there probably are still opportunities to use this more and more effectively for our patients with acne. And then we do have opportunities to optimize monitoring for both spironolactone and isotretinoin. So I hope you found this video helpful. If you have, please give it a like and consider subscribing to the channel. Your support means a lot to me. Ask me your questions about acne and rosacea in the comments below. And until next time, see ya.